evening, friends. Just let me know if you can see me live so that I can start today's session. So I can just waiting for the confirmation that I'm live. Can anyone put it in the chat if they can see me live? Okay. So I have a visual confirmation that I am live. So welcome to this session. In this session, we are going to talk about ABG analysis. Again, a very important topic, both from purely theoretical questions as well as practical questions. I mean, you may be given a clinical question and then you will have to analyze, if it is a acidosis, alkalosis, compensated, non-compensated. And at the end of this session, you will be able to analyze any ABG in less than 10 seconds. So that's my promise, that I'm going to share a very unique algorithm at this session, in this session, that you can analyze any ABG with confidence in less than 10 seconds. Now it's a very big claim, and I will make sure so that forget about being afraid of an ABG, you will analyze it in less than 10 seconds. So welcome everybody. And some students have said that my audio visual is not very clear. Now what happens whenever we go live? Generally, YouTube will try to reduce the streaming quality. So basically, you have to go and increase the quality to 72 Mbps. So if you click on the video, there is a setting button, and in the setting button, quality is normally like auto. So you have to choose that recommended ki jagah pe 720. Okay, so that is one reason why you may not be able to see my videos in a proper way. So let's start. Uh, let's start today's session. So first, what is ABG? What is ABG? ABG is basically arterial blood gas analysis. So basically, we take the blood from artery, generally a peripheral artery, and we do the analysis. So whenever we are looking at that any ABG, there are three basic questions which we want to answer. Three very basic questions. The first critical or basic question is whether we are looking at a case of acidosis or alkalosis. Very simple. Then, once we have decided it is acidosis or alkalosis, the second basic question which we want to answer is it respiratory pathology or metabolic? Okay, so what is the primary pathology for acidosis or alkalosis? So the second basic question which we require to understand, to solve for whenever we are looking at an ABG is what is the pathology behind it? Is it a respiratory pathology? Is it a metabolic pathology? And the third, so this will tell you the diagnosis. And third thing is, what do we do about it? Which means, is it an uncompensated, partially compensated, or fully compensated acidosis or alkalosis? Because based on that we will undergo, we will design whatever treatment we have to give. So whenever we are looking at an ABG, these are the three critical questions we have to answer. Number one, is it an acidosis, alkalosis? Number two, is it a respiratory or a metabolic primary cause? And third is it uncompensated, or is it partially compensated, or is it fully compensated? Right now, before we go ahead and analyze any ABC, we have to remember normal values, because in the examination maybe the normal values are not given, and generally it will not be given. So let's look at some of the normal values which you have to remember. So first is the pH. So 7.35 to 7.45, this is the normal pH of arterial blood. Now remember, anything below 7.35 will be acidosis, and anything more than 7.45 will be alkalosis. Is it clear? Right? Then we need to know the PCO2. So what is the normal PCO2? It is 35 to 45. Then we also need to know the bicarbonate levels. So the normal bicarbonate level is 22 to 26. Next, What is the normal anion gap? Because we will look at high anion gap metabolic acidosis, or normal anion gap metabolic. So 8 to 16 is the normal anion gap. And last, what is the PO2? So it's an arterial blood. So PO2 will range between 80 to 100. So these are the normal values which you have to remember. These are super critical, because in examination, if you get anywhere confused with these values, you will not be able to answer the question. So before we again, I'll show you that unique algorithm by which you can solve any ABG in less than 10 seconds. Let me just, explain the ABG equation, okay, or the acidity equation. So remember, it is carbon dioxide plus water forms a reversible reaction to form bicarbonate, bicarbonate plus H plus ion. Okay, so this is very, very clear. Now, what I want you to remember from exam point of view is carbon dioxide always denotes acid. So whenever the carbon dioxide is increased, it will be acidosis. Similarly, bicarbonate denotes alkaline. So whenever bicarbonate is going to increase, what will be alkalosis. Okay, and whenever primarily, now when we talk about, these are the only two primary mediators. So think, when carbon dioxide is increased or decreased, will it be a respiratory cause or metabolic cause? Just think for yourself. So whenever carbon dioxide is increased or decreased primarily, it will be a respiratory cause, and whenever bicarbonate is increased or decreased primarily, it will be metabolic cause. So these are some of the rule of the thumb you have to remember for your examination and to analyze in ABC. Now let me show you that algorithm. So the first thing, whenever an ABG is given to you, either you are in an ICU setting or as an intern, you see an ABG, or in examination, the first thing you see is pH. And the moment you see pH, only three things can happen. Either the pH is decreased, or the pH is increased, or pH is normal. So if pH is normal, probably it may not be any acidosis or alkalosis, or even if it is there, it is a fully compensated derangement, which means even if it was acidosis or alkalosis, it is fully compensated. If the pH is decreased, then obviously it is a case of acidosis, and if the pH is increased, it is a case of alkalosis. So we remember 7.35 to 7.45. This is the normal pH range. So whenever the pH in your ABG is below this, acidosis; above this, alkalosis. So by this we will answer our first critical question, that when you are given an ABG, is it an acidosis, is it an alkalosis? Now let's move forward. Let's say it is an acidosis. Now what we will do? We will look at the PCO2 value. And if the PCO2 value is increased, we know it's a respiratory cause. If the PCO2 value is not increased, which means it may be normal or decreased, it is a metabolic cause. Clear? So first thing is, we saw it is an acidosis or alkalosis. The moment we know it is an acidosis, first thing we see is PCO2. If the PCO2 is increased, for respiratory alkalosis, PCO2 will always increase, which means either it is normal or decreased, then it is a metabolic cause. Any doubt in this? Let's look at what we will do in alkalosis. Even in alkalosis, look at the PCO2. In alkalosis, if the PCO2 is decreased, the cause is respiratory. Or if the PCO2 is either increased or normal, then it is a metabolic cause. Very, very simple. So to determine whether it is an metabolic cause or respiratory cause, you always look at the PCO2. So if PCO2 is increased in an acidosis, it is respiratory acidosis. If the PCO2 is decreased in an alkalosis, it is a respiratory alkalosis. Otherwise, it will be always metabolic. And once you have known this, let's look at how will we decide if it is compensated or uncompensated. So obviously it cannot be fully compensated, but let's say for respiratory cause, look at the bicarbonate level. If the bicarbonate level is normal, it is uncompensated. If the bicarbonate is increased or decreased, it is compensated accordingly, which means no. Now let's look at the metabolic. Again we will look at the PCO2, because metabolic, the primary derangement is of bicarbonate, so PCO2 will change. If the PCO2 is normal, then it is uncompensated. Increased or decreased, then it is partially compensated. Is it clear? Don't worry, I know that this algorithm may look a little difficult when you are trying to learn it, but I'll show you in practical situations how you can solve any ABG in less than 10 seconds. So just give me few minutes to discuss some of the other theory points. So when we talk about respiratory acidosis, the causes can be either respiratory or central. So when we talk about central, very simple, there can be either damage to the brain, which is leading to a depression in the respiratory center, so there is a carbon dioxide retention. So diseases like CVA, drugs like morphine, anesthesia or sedative, or CNS infection, all these are important central causes for respiratory acidosis. When we talk central causes, when we talk about respiratory causes, then anything like airway obstruction, COPD exacerbations, ARDS, pneumococcosis, barotrauma, or certain neuromuscular causes like polio, ALS, myasthenia gravis, or muscular dystrophy. All these, what will happen? They will lead to decrease in the respiration, so carbon dioxide retention. So whenever carbon dioxide is retained, what you will have? You will have respiratory acidosis. Any doubt? Management is basically positive pressure ventilation, or maybe whatever the cause may be. And remember, for respiratory acidosis, we do not recommend an aggressive treatment. Why? Because if this carbon dioxide washout may lead to cerebral vasodilation, and this may precipitate seizures. So aggressive treatment for respiratory acidosis is never advised. Let's look at the important causes of respiratory alkalosis. So causes can be pulmonary edema due to CHF, hysteria. Hysteria mein what happens? The person is hyperventilating. So this will lead to carbon dioxide washout. Even CVA can cause hyperventilation and cause respiratory alkalosis. High pulmonary altitude edema, pulmonary embolism, again very important, flail chest, because the patient will not be breathing, he is having injury in the chest, so he will not be breathing, sepsis and heat exposure. So all these are important causes of respiratory alkalosis. How will it present? Dizziness, vertigo, because of the shift of the intracellular shift of the sodium and phosphates. This can also precipitate arrhythmia and tetany also. How do we manage? So manage is paper bag breathing. So you basically breathe in a paper bag so that you inhale whatever carbon dioxide you have breathed out, so that the carbon dioxide level in the blood increases. Let's look at metabolic acidosis. So when we talk about metabolic acidosis, you have to remember that we should know that it is a normal anion gap metabolic acidosis or HAGMA. So I'm not going too detail into that. So I'll just list the causes here, because again, metabolic acidosis complete class can be taken. So when we talk about anion gap, what we have to do is major cations minus major anion. So what are the major cations? Sodium is the major cation of the blood, and major anion is chloride and bicarbonate. So we take the level of sodium and subtract it from the level of chlorine and bicarbonate. So normal anion gap is 8 to 16. So there are some causes of normal anion gap acidosis, like gastric losses that can happen in. Sorry, let's look at the HAGMA first. So HAGMA, the mnemonic is kilogram. So ketoacidosis, isoniazide, lactate, oxyproline, so glycols, renal failure, aspirin, methanol. So all these are important causes of high anion gap metabolic acidosis. Okay, and all these have been asked multiple times in examination. When we talk about normal anion gap, so it can be gastric losses like diarrhea, small bowel fistula, or even a urinary diversion procedures. Renal losses in terms of renal tubular acidosis can also cause normal metabolic acidosis, and ingestion of inorganic acids can cause metabolic acidosis. Let's quickly look at the metabolic alkalosis causes. So I'm just listing so that you remember for the examination. So when we talk about metabolic alkalosis, it is divided into chlorine responsive, chlorine resistance, and intermediate. So when you talk about responsive, it will be vomiting, loop diuretics, and cystic fibrosis. Intermediate milk alkali syndrome. So all these will cause metabolic alkalosis, but some are responsive, some are not. When we talk about resistance, hyperaldosteronism, and 11 beta and 17 alpha hydroxylase deficiency, and Bartter Gilderman or Diddle syndrome. So all these are super important causes of chloride resistant metabolic acidosis. How do again it presents? So dizziness, vertigo, because it's an alkalosis. So all the features of alkalosis will be there. Even tetany can happen. So management is primarily according to the underlying causes, and you can give chloride rich fluid if it is chloride responsive. So this completes the theory part. Now come to the interesting part. What exactly exams question have been asked and how you can answer it. So the first question is: a patient presented with history of vomiting for 3 days. On examination, signs of dehydration was there, and the patient was found to have raised creatinine, pH is given, PCO2 is given. Now you have to analyze it. So the first thing I told you is look at the pH. You can see it is acidosis. Clear? First answer given. Now I have told you that look at the PCO2. Look at the PCO2. Okay? And when you look at the PCO2, what do you see? What do you see? PCO2 is basically decreased. So if it is a respiratory cause, then PCO2 should increase, but here it is decreasing. So definitely the cause will be metabolic. So the correct answer will be metabolic acidosis. Any doubt in this? Any doubts? So within 10 seconds we have been able. First we looked at the pH. pH was 7.22. So we know it's an acidosis. We looked at PCO2. If it is a respiratory cause, PCO2 has to be elevated. But here, rather forget about elevation, it is actually dropping down. So it's a metabolic cause. Within 10 seconds we have been able to answer it. Any doubt till now? Let's look at another question. Uncompensated metabolic acidosis source. Okay, so we are looking at acidosis. So acidosis may CO2. Okay, so it is called metabolic. So metabolic cause bicarbonate will change primarily, and because it is an acidosis, bicarbonate is an alkali, so bicarbonate has to fall down. So there, because it is an acidosis, the pH has to decrease. So these two options goes away, and there has to be a decrease in the bicarbonate because we are talking about acidosis. I told you bicarbonate is basically alkali. Okay, so when alkali increases, it is alkalosis. When alkali will decrease, it is acidosis. Clear? Within 10 seconds, let's analyze this. Again, within 10 seconds, you will be able to analyze it. ABG 7.2, we can clearly say acidosis. Any doubt in this? And that also uncompensated, because if it is compensated, it will come closer to this range. Okay, now you have to look at the PCO2. Remember, so PCO2 is increased. If PCO2 is increased in acidosis, it is respiratory acidosis. Okay, so respiratory acidosis. So we have got respiratory. Now what will be the compensation? Compensation will be metabolic alkalosis. So is metabolic alkalosis happening here? Can anyone tell me? Is metabolic alkalosis here? So normal bicarbonate is basically how much? Can anyone tell me how much is the normal bicarbonate? Remember, so normal bicarbonate is 22 to 26. So here bicarbonate is increasing, so definitely there is a compensation metabolic alkalosis which is happening. So the correct answer will be metabolic alkalosis. Okay, let's look at another question. So here a 24-year-old beggar is found unconscious. Okay, pH 7.25. Normally when we see the pH, we know it is an acidosis. Any doubt? Now we immediately will go for PCO2. PCO2 we are seeing it is increased, so the cause will be respiratory. We see bicarbonate. Bicarbonate is within the normal range, so it is uncompensated. Any doubt? Not even partially compensated. Okay, so uncompensated respiratory acidosis. Again, within 10 seconds you are able to answer. Okay, now let's look at this question. Again, try and answer this. 7.3, so it is acidosis. Immediately look at PCO2, it is increased, so respiratory acidosis. Look at the bicarbonate level. Now bicarbonate is 22 to 26, so obviously bicarbonate has increased by 2, so obviously compensation is started, but not completely, because pH still is not normalized. So partially compensated respiratory acidosis. Any doubt? So within 10 seconds we are able to solve any. Let's look at this question. A 65-year-old, chronic smoker, COPD, whatever, I'll not read anything. I'll just look at the pH. Now, pH says me it is acidosis. PCO tells me it is respiratory in nature. Okay, so respiratory, and because bicarbonate is increased, so we know it is partially compensated. Again, any doubt? Let's look at this question. Okay, pH, so it is acidosis because pH is decreased. PCO2, now here PCO2 is actually decreased. So whenever in acidosis PCO2 is increased, then we know it's respiratory. Otherwise, even if it is PCO2 is normal or decreased, it will be metabolic acidosis. Now, for metabolic acidosis to compensate carbon, okay, so this is, and we can see the bicarbonate is severely decreased. Is it clear? So let's look at another question. A 6-year-old child is admitted to hospital with severe asthma. Again, I'm leaving that. See, pH is normal. Can you see? pH is normal. Okay, towards the acidotic side, but pH is normal. But look at the PCO2. Is it drastically increased? So we are looking at a respiratory case and probably acidosis, but it is fully compensated. Okay, why it is compensated? Because bicarbonate is increased. Okay, I told you this is respiratory acidosis. 7.35 is like, remember, 7.35 to 7.45 is your normal pH, so it has just been compensated. Okay, let's look at this. Again, pH is this 7.46, so it is clear-cut case of alkalosis. Let's look at the PCO2. PCO2 is 49, so PCO2 is increased. If PCO2 is increased, if it was decreased, it was respiratory. If it is increased or normal, it is metabolic. So metabolic alkalosis, and it is partially compensated, not completely compensated, but partially compensated. Okay, so you can see you can solve literally any ABG in less than 10 seconds. Alkalosis, okay, look at the PCO2. PCO2 is decreased. So in alkalosis, look, again remember, if it is acidosis, the PCO2 you have to see, and if it is increased, you know it's respiratory, otherwise it is metabolic. Similarly, in alkalosis, PCO2, if you see, it should be decreased. If it is anything increased or normal, it is metabolic. So here you see it is decreased, so the correct answer will be respiratory alkalosis. It is alkalosis, and why respiratory? Because PCO2 is decreasing, so the primary cause is PCO2 is decreasing. Okay, let's look at another question. So all these ABGs in less than 10 seconds you are able to solve. pH is 7.55, so it is alkalosis. PCO2 again is decreasing, right? PCO2 is decreasing, so it is respiratory alkalosis. Any doubt? Let's look at this question. So I'm making you practice so many questions so that you are able to confidently do it. Alkalosis, any doubt? And you can see PCO2 is normal. Okay, so in alkalosis, if PCO2 is decreased, then we can say no, it's decreased. Sorry, 35 to 45. So it is decreased. So it is respiratory alkalosis. Okay. Again, let's look at this pH. So this is alkalosis, and PCO2 is actually decreased. Okay, so this is respiratory alkalosis. pH is, so this is acidosis, and this is respiratory alkalosis. Is it clear? So you are able to solve again alkalosis, PCO2 is decreased, so respiratory alkalosis. So this brings us to the end. So again, I'll just take you through the algorithm once again. Okay, so remember what you have to do. First, you have to look at the pH. Based on the pH, you have to decide if it is acidosis or alkalosis. If it is normal, then forget it now, for now. Okay, if it is acidosis, in both the situation, look at the PCO2. In both the situation, look at the PCO2. And we have to primarily rule out respiratory. So in acidosis, if it is a respiratory acidosis, we know that PCO2 will be increased. Or if it is decreased or normal, in this case, it is respiratory. In this case, it is metabolic. Okay. If it is a respiratory alkalosis, then PCO2 has to decrease, or PCO2 increases or normal. So in this case, it is metabolic, and this case, it is respiratory. Okay. And when you talk about compensation in respiratory, because the primary cause is PCO2, so bicarbonate should change. Okay, bicarbonate should be, because it is if it is an acidosis, the bicarbonate has to increase to compensate, because acidosis, so alkali has to increase to compensate. If it is an alkalosis, the bicarbonate has to decrease, and similarly for here. So this is the algorithm. If you remember it, you will be able to solve any ABG question in less than 10 seconds. So thank you so much. This week we have taken almost 3-4 sessions, live sessions, our mentorship session, and we will try to continue taking these sessions. Okay, and most of these sessions will be at 4:30 every day, Monday to Friday. It will be there. Out of 5 days, 3 or 4 days, I'll be taking these sessions at 4:30, and soon we will discuss a lot of high topic MCQs. Okay, so if you have any doubt, any suggestions, anything, I would love if you can put that in the comment. Okay, and if you like this session, please do share it with your friends so that they can also look at this class, and they can also benefit from it, and they can also join for our free live sessions at YouTube.